the Accountable Care Organization Sole Member Annual Meeting for calendar year 2025. Meeting is now called to order. So for the record, please note that Jorge Farjul is representing Deputy Mayor Helen Arteaga Landaverde, and Karen Sanhilier is representing Molly Wasso Park, both in a voting capacity. So next on the agenda is the adoption of the minutes of the HHC ACO Annual Membership Meeting held on December 19, 2024. Are there any questions, comments, or suggested changes? May I have a motion?
So moved.
All in favor, please say yes.
Yes.
Opposed, say no. So the minutes are adopted. Next on the agenda is a resolution for the annual election of the officers of the ACO. Ms. Meager, please read the resolution into the record.
Just need the slide. Okay. Authorizing that each of the following persons be elected, effective immediately, to serve as a director of HHC ACO Inc. Board of Directors in accordance with the laws of the state of New York. Do you want to give you the name?
It's okay. I'm giving folks a chance to read it. Okay. So any questions? So all in favor, please say yes.
Yes.
Opposed, say no. So resolution approved. So Ms. Meager and Dr. Okolo will now provide an update of the activities of the ACO.
Okay, Lisa, can you go one slide before? Yes. Okay, great. So, good afternoon, everyone. I'm Megan Maher. I work in the managed care team at Health and Hospitals, but also serve in the capacity of the Chief Operating Officer for our Medicare ACO. Our exciting news starting in 2026 is that we have 2 new community partners that we've recruited to be part of our ACO. They are Urban Health Plan, which is an FQHC network throughout the city, where we expect to have approximately 250 new patients attributed to our ACO, and Union Community Health Center, which is predominantly in the Bronx, and we expect about 100 patients from their participation. So they have been onboarded to our ACO. We have monthly meetings that they've started to attend, so we're really excited for their partnership. We connected with them through our other community partner, Community Healthcare Network. So we're really excited. We feel like all 3 community partners are very mission aligned with Health and Hospitals. So we're excited to see where that partnership goes. If we could go one more slide. Yep. So this is the financial results of our performance year in calendar year 2024, which were announced in the fall of 2025. So these are lags because there's run out of claims to really understand how the population's healthcare experience performed. So the wonderful news is that we have 12 consecutive years of saving the Medicare program money. So in 2024, we saved Medicare $9.8 million, and we were able to retain $7.2 million of that 9.8. So we are in the process of finalizing MOAs that we have to have signed with each of the physician groups in order to effectuate those incentive payments, which we hope will be happening in the next month or so. And then looking at 2025, so our performance in calendar year 2025, we expect to be finalized in the fall of 2026. But this is our projection thus far from the claims data we have from CMS that we are on track to earn shared savings. You can see on that second bullet point that our threshold to earn savings is to have a balance of $639 per beneficiary. We're currently at $723, so we want to stay above that $639 mark. But we will be actively monitoring that and hope to achieve a 13th year of consecutive savings for 2025.
That's per member per month.
Yes. Okay, I'm going to turn it over. Oh, yes.
To what do you attribute the savings to?
It's a great question. We do have a lot of clinical projects that Dr. Okolo is going to go into in terms of trying to actually care manage the population that we are at risk for. At the end of the day, the goal is to take the premium dollars that Medicare has for these members and help manage their health care so that we spend less than the premium. And if there's leftover money because people are getting quality care, then we have money left over that we're saving the Medicare program. And one of the important components is that this is value-based, so there are quality metrics that we have to meet because you don't want to skimp on care and then provide bad quality of care, right? We want people to be engaged and be getting their preventative health care. So it's a constant data exploration to try to figure out, are there certain cost categories that we're doing better? Like, for example, inpatient care. Is there work that we could be doing to keep people out of the hospital for unnecessary admissions, right? Because that would save a lot of money in the Medicare program. Or are we getting folks their medications so that they don't have exacerbations that they then are going in for unnecessary care that we could have controlled? So there's no secret sauce. It's just a lot of work trying to identify what are the needs of the population and how can we intervene, if at all.
And for my quick education, technically speaking, do you estimate how many people are Medicare patients and then you get that funding ahead of the services, or once you provide the services, you apply for the funding and that kind?
Exactly. So this is based on what Medicare has in the bank, because this is all of these members in the ACO have Medicare, traditional Medicare fee for service. So it's really Medicare saying, okay, here's the budget that we've set for the ACO, and we expect you to, of the premium dollars we have to pay out claims, we want to hold you to spending at a certain level. And if we perform better so that we're saving the Medicare program money, then that's money that we're able to save and share with the doctors that are in the ACO.
Okay, so you're estimating how many people you need to fund annually.
Right. So Medicare will give us that budget. So they'll say, based on where these patients have been getting care, right? If they're going to Bellevue in the last several months, they get attributed to Bellevue.
Okay.
So yeah.
Okay.
So it's all a perspective. So that as of 2026, they'll say, okay, who had spending that would affiliate them with health and hospitals and our community partners, and that's our locked-in population for 2026 that we're trying to manage.
Thank you.
Megan, can you talk a little bit about whether you see going forward other groups joining us? What would be? I mean, it's nice that these three groups have joined. There are a lot of other groups that share similar missions to us. How would another group plan to do? Is that something you see happening?
Right. It's a good question. I think that there are pros and cons to expanding the network. When you expand the network, you have more members, and so normally when you expand your risk pool, you have a little bit more protection, because the more people you have in participating, the more you can accommodate really expensive care. I would say that there is risk if the providers that we would want to expand and include in our network are not very engaged in high quality care management, that they could be mission driven, but maybe not performing as well as we might like. And so I think that's a balance that we want to try to strike. And I would invite you to weigh in on this as well, Anthony, but I think it's a question of how much vetting do we want to do for expanding our population versus how much we should internally be trying to manage the population we already have to try to achieve better financial results and quality results. So I think I think we do such a good job with the ACO that there might be a secret sauce that we could bring to other community providers that we might want to engage them. But if we expand too big, we might see our performance start to swing in a different direction. Yeah.
I agree. I was going to ask, because you mentioned about how much vetting we can do. What vetting can you do? You're looking for physicians that have, that are mission driven in the same way we are, but also who are not overutilizers, who are high quality outcomes. Is there a way of actually monitoring that? Because they're not currently ACO
Right.
members, right? So is there a way of doing that?
Yeah. So we contract with a data vendor called Health Endeavors. And they have access to a lot of CMS data. They manage all of our data, but they also have access to other ACOs. And so there is possibilities of working with them to say, oh, if we want to explore this provider with this tax ID possibly joining us, could you give us some high level, because a lot of this information is public because it's Medicare claims, that they could say, okay, historically this has been their financial performance. So that's probably been our best tool in trying to assess, and we did do that for these two new partners to try to look and see. I mean, we didn't do a super thorough analysis, but to try to just see what the predictability would be of having shared savings.
Theoretically, hopefully it'll be improved once they've joined us.
Exactly.
And how much of the improvement over time has been through Epic and the value of what Epic brings to both quality outcome issues and
Right.
utilization and so on, and not bringing groups that don't have our HR, does that also open a bit of
Exactly.
a risk?
I mean, from a quality perspective, CMS has moved to a lot of the data that we're sharing to show our quality performance to be electronic. We used to do a lot of chart chases, and so if we did not have Epic, it would be very laborious for us to try to pull all of that data. So I think in order for us to meet the shared savings target, we have to be at a certain quality threshold. So I think from a data perspective, that has probably been the most meaningful piece. I think it's interesting, the Epic data that we have is really showing the health and hospitals patient experience. And we do have patients that have traditional Medicare that come and get care at health and hospitals who are not in our ACO. So they might more frequently visit an outside community provider. So I think that's data analysis that we're trying to do to say, oh, well, if they're coming to us for some care, could we try to incorporate them into our ACO? So that's another way we can try to leverage Epic. I don't know if anything else comes to mind.
No, Megan, I think you really answered it. I think the one thing I'll emphasize is the quality reporting piece. That's, someone asked a question about vetting. I think one of the key things we need from our partners is the ability to do our quality reporting to the sophistication that we do it. So we work with them. We know with our two partners, we know, for instance, Urban Health Plan has the same EMR as Community Health Network. So we're not as worried about how they're doing in terms of quality reporting or if they'll be able to meet what we need to report to CMS. We're currently working with Union Community Healthcare to make sure that their EMR is able to do the quality reporting that we need. So I'll say that's, if not the biggest, one of the biggest vetting that we do to make sure that you can participate, we can get a sense of your population, we can report accurately to CMS, so it doesn't hold up to CMS. But I agree with everything Megan said.
I'll just add, I mean, I work at Urban Health Plan, so I can definitely confirm that we can, you know, our quality reports, we use eClinicalWorks, so we don't use Epic, but it's pretty matched to that, and we collect a lot of data, so, yeah.
And HHC is at baseline, right? Collect a lot of data to report to their various agencies. So we already know, even by partnering with these agencies, they already have some level of infrastructure on how they report to their external partners.
How close do you stay to the predictions? I'm looking at page 6, and how, when you have data like this, how?
I wouldn't, it's not ironclad. There is high variability. Like, for example, we have no data from the fourth quarter of 2025. So I know that the flu was pretty bad this year, so that we might see higher swings. But the data, in addition to the spending, CMS is constantly doing a risk adjustment to show for your region that you're in, what would they expect the rate to be, the spending rate to be. So there's so many variables that are moving up and down that I do find it a little bit difficult to feel solid that that's going to be our performance when they release it in the fall. But I'm optimistic from just the historical experience that even when throughout the year it seems like we're getting close to maybe not meeting the shared savings target, when they do the final risk adjustment at the end of the year, we seem to always do pretty well.
Well, because we take care of a sicker group of people,
Sure
so
do.
when they do the risk adjustment,
Yeah.
we come out. But also, we should be okay. Remember that the flu season was bad for ED visits, but not bad for hospitalization.
Okay, great.
Hospitalization rates were pretty low from the flu,
Good.
just disastrously high ED visits. But they're way less expensive,
Right.
compared to people needing to be in the hospital.
Good.
Thanks. Any other questions? So now you're not done with your presentation, right? So
I'm going to turn it over to
Yes.
Dr. Colo.
Good afternoon, everyone, and thank you again for having us. I'm pleased to talk about our quality performance for performance year 2024. So as many of you may know, for us, in addition to obviously making shared savings and not exceeding our financial benchmarks, the other way we can ensure to make shared savings by a certain threshold on our quality performance. And for CMS, that's 40 percentile. So the 40th percentile for 2024 was that 77.05. And we exceeded it based on one of the ways that we do quality reporting, which was through the web interface. We had a score of 78.06. So that way that we reported was what Megan was describing, the web interface, which was the manual reporting. CMS will give us 250 patients randomly that they'll tell us we need to report certain metrics for. We'll fill it out, we'll send it to them, and then they give us our score. That method of reporting ended as of this year. The new method, as Megan described, is the electronic reporting. So the denominator has changed. It's no longer based on just ACO patients, but all of health and hospitals, so about approximately 500,000 patients we're held up for. And we have to do it through our EMR, right? So the way it works is there's a file format that aggregates all the data from our EMR and sends it directly to CMS. And CMS wants this because obviously you can't do as much data manipulation as maybe could have been done through the previous method. So they feel more confident with this method, and we're of course more quick, thankfully, to Epic to answer your previous question, that we can do this. With that method in 2024, we ran both because we wanted to prepare for when we were mandatorily going to report electronically. We had a score of 53.91. So that's obviously less than the 77.05. But what I will explain to you in a couple of slides, so hold with me, is even with that score, we would have made maximum shared savings. And I'll explain exactly how in a couple of slides. We can go to the next slide. So with this slide, I just wanted to emphasize the difference in the two reporting structures. So starting with the web interface versus the electronic, we look at the three highlighted measures: depression, diabetes, and hypertension. What changed was the denominator. So whereas on the left, the denominator was just over, at the time, 5,000 and change ACO patients, going forward, we're responsible in the denominator for over 500,000 patients. And these are patients who may not even, are regardless of payer, right? They may not be in the ACO, they may be Health First, they may be MetroPlus. They also may not be getting their primary care with us. So they may be getting the plurality of their care through specialty services with us, but not necessarily primary care. So this is not a unique trend to us, but all ACOs notice a slight drop in the performance of those metrics when you went to electronic. So now we're going to talk about how CMS provided some provisions to make sure we can still make shared savings even with this adjustment in how we report. So we can go to the next slide. So the way we've done in the past, and the way we've always made shared savings, is by exceeding the 40th percentile of our overall quality score, which we've always done. I talked before about the 53 percentile that we scored that would have still made shared savings, and that's because of the other criteria that CMS introduced last year on the right, which is popularly called the 1040 rule. What that means is, if you don't meet it the way of surpassing the 40th percentile overall, you can get your maximum shared savings by a quality score where in one outcome measure, whether it's readmissions, diabetes, or hypertension, you exceed the 10th percentile, and one other measure, you can exceed the 40th percentile. Since our inception, when we've gotten quality scores, we have always made shared savings based on that criteria. Always and constantly. So even with that score of the 53.91, you would have still made maximum shared savings. Now, I also want to say, even if for some reason, God forbid, we didn't get number 2 or number 1, we can make partial shared savings. And what we do then is whatever our quality score is, you multiply it by 75%, which is the percentage of shared savings we get. That becomes the new percentage of shared savings that we would get. So we're very confident in the plan forward. Definitely from a quality perspective, we will be making shared savings based on our historical performance and our ability to report on these numbers.
can I ask you, what are the two measures that you think you're going to hit?
Two measures.
What are the two measures that you'll hit on number
sorry,
two?
What I meant is the two ways you can make shared savings. So it's either you exceed 40th percentile in your overall quality score, or in one of the outcome measures you exceed or meet 10th percentile, and then in the other, and for the same measure, and at the same time you exceed 40th percentile in one of the other measures. And those measures, if you go to the slide before this, these are the 6 measures I'm talking about here. So in diabetes, hypertension, readmissions, we'd have to exceed 10th percentile. And in one of the other ones, we'd have to get higher than 40th percentile, which we did both 2023, 2024, and the years past.
Or you're not at 10%, right?
For which one?
Oh, this is 24. You're saying in 25 you would be, which one would be in the 10th percentile?
So we'd have to exceed in either hypertension, diabetes, or readmission. We'd have to meet or exceed 10 percentile.
And you're,
For the diabetes and hypertension, we tend to, always.
you tend to. Okay, but so A1C is dragging that down in 24. Is that?
So sorry, that's not the percentile. The percentile is on the, I guess, the right. So you see middle third, that would be where our percent. Those are the
Right, the
scores.
middle
That's the
third's not the
point,
top,
yeah.
isn't the top. Middle
Right.
third would not be the top.
Below
10%.
33% then.
Sorry, what happened?
That's below 33% on all those measures, so it's not in the top 10 percentile.
Right.
Right. So readmissions, diabetes, hypertension, we've always been above. Let me think about this. We're always above
The 10th percentile.
10th percentile,
Yeah.
right? Yeah.
You're thinking about right. So those were above the 10th percentile.
Am I missing?
So what does middle third then mean and top third mean?
So that's like
That's still
middle third.
33,
That's how
66,
we do
and
compared to other ACOs. So that would be. I'm not sure the actual numbers, but that's how they give it to us in terms of our rank.
So middle third would be above the 10th percentile.
Right. Yes. My apologies.
Anyway, part of the reason I was asking you that question is because I was thinking that since we have a strategic committee, that we put in key performance indicators that we track and so on, it may be useful to know that the two that you're really going to work on, because you need everybody to work on it,
Right.
not just you, right? And that was what I was going with it.
And you're also right. And we work really closely with our pop health colleagues. In fact, for diabetes and hypertension, almost exclusively with our pop health home care colleagues, both at the facility level and at central office. So definitely open to more talking with districts.
And that's a really important point, Jose, because I think we look at this in isolation, but in the broader picture, these are the same measures on the board report, the same measures the Metro Plus uses, the same measures that CMS's 20 other value-based purchasing programs use. So there's a lot of alignments. We're looking at it through the lens of the ACO, but there's so many other inputs for improvement.
I would also just flag the CAPS survey, which is the consumer survey of their perception of their care, and the 30-day all-cause unplanned readmission rate. The fact that that says bottom third, those are the most challenging metrics, and that's not distinct to health and hospitals. I think that's true across the healthcare industry. But so I do think that some of those other metrics that's really going more towards the clinical care that we're giving on an outpatient basis, those are ones where we tend to perform better.
Thanks.
I have a question just mathematically, right? So you're touting that you're better than the 40th percentile, but wouldn't you want to be in the top percentiles?
I think that's the goal. Our goal, we're not like comfortable just sitting and saying. I think our goal, we are continuing to do, and I'm going to get to some of the clinical initiatives that we believe can contribute to our progress, as well as our collaborations and what other departments are doing, like Ted pointed out. Our goal is not to stay in these percentiles. Our goal is, in fact, we'll get to in the clinic, and what I'll emphasize is, particularly with the 30-day all-call readmission, that's really the focus of the ACO this year. It's a utilization measure that we really feel like we really need to put all hands on deck for, and we're working with quality and safety. I'll highlight some of our clinical initiatives and how that addresses that, but our goal is to really not sit there. You're absolutely right.
And also mathematically, I mean, I see the wording in the rank, but when you say top third, middle third, and bottom third, top third for me means better than 33 and a third percent. Middle third means from 34 to 66, right? So like, it's just a little confusing when you're saying 10% and middle third mathematically does not make sense. So maybe you want to put percentages there or what exactly that means.
Okay, absolutely. Yeah, I think what we'll do in subsequent meetings, what happened?
The technical difficulties, if you want to use this microphone, then we can
I'm so sorry.
make sure that it's recorded permanently.
Okay, great, yes. I'll start again. Yes, our goal is to not settle there. As far as how we're reporting the rankings, we'll make sure it's more consistent with the language I'm using. That's absolutely great feedback, and we'll do that.
Just one other question relating to the caps. And as you said, I know those are always traditionally going to be very, very difficult because you're looking at perception of patients and how they see things, whether or not they're getting services or not, how they perceive it or not. But it does seem as if we're well below the other. It says here all ACOs average. So any thoughts as to what the rationale, because these are things like ability to get appointments, right? And how is your doctor coordinating care and all kinds of things like that. What is your sense of why we might be below? And then what is the, I guess, direction to see how we can address that?
I'll give you a good example of that. So one of the questions asked with the CAP survey is with my professor. Health and hospitals only one for the ACO. We scored 90 percentile, but the average ACO scored 93 percentile, right? So it's not that we're doing bad at all. 90 percentile would not be bad in any metric. I think what's challenging is a metric that's compared to other ACOs, and how, as a large safety net hospital, we can do compared to other ACOs with various different levels of resources. So I think from our end, and to your point, we will keep trying. We will keep working with our CAPS teams in quality and safety. We will keep thinking of ways we can really improve how we communicate to patients. The eye care program that we have here at Health and Hospitals will continue to work with them. But I do want to emphasize it's not so much, we're not doing bad at all. I think it's a very hard metric to really exceed how overall the country is doing.
And just another point there to support what Anthony is saying. The metric here represents a lot of different inputs, your hospital experience, your outpatient experience. And on the outpatient side, we're at 88% top box satisfaction now, which is about 10% higher than it had been, absolute value. Inpatient-wise, I think we're closer to 75% or something like that. So it gives us an ability, as Anthony's saying, to like see where we want to put our focus and efforts, to see where we can have the most improvement to drive the overall score.
And care coordination, which is the hallmark of our ACO initiatives, should be contributing to the patient care experience. If the patient feels that their health system cares to follow them through all settings of care, checking in with them, that in itself is an intervention for how we, hopefully, our patients feel with their patient experience. So we're continuing to build on that in addition to all the other things.
One of the ways, I mean, as you said, there's so many different players that are communicating with the patient. So obviously the hospital will be doing some of that. I'm thinking in terms of things like even the 30-day readmit, but also with the caps. But you also have the HMO, and again, with us, that's Metro, and you also have the ACO, and I'm interested, I guess to some extent too, how are these coordinated, and what does the ACO do differently as far as outreach and so on in managing these cases, as opposed to what Metro Plus is doing, as opposed to what the hospital discharge people are doing, and so on?
I don't know if we're doing anything differently. I think we're doing things, so the way the ACO clinical projects work, one thing we do is we make sure we cover all ACO patients, but it should be something that's scalable to everyone. So we work with Metro Plus. We meet, I meet with Alina and Julie Myers all the time because we're thinking of the patient consortium as a whole. And also to the point of our denominator has changed anyway to all of H&H. So everything we do is not limited to H&H. It should cover all ACO patients, but it's not limited to ACO patients. So I would say we really build on the post-discharge workflows, the care coordination pathways that many of the others do, and if anything, enhance it with our team and our ability to support those teams. That would be my short answer.
Yeah, totally. I think the important point, which I totally agree with, is we want every patient in our system to get the same care, whether you're a Medicaid patient that's 66 or an ACO patient that's 66. As Anthony's saying, that's where we work very closely behind the scenes to look at the data, but these are indicators. We have deeper data that show where we can make improvements across the board. And quality in the patient experience is a good example of that, just delineating between inpatient and outpatient, things like that.
So these are just highlights of some of the clinical initiatives that we did for performance performance year 2024, and there's continuing to be built on and a lot of change in subsequent years. I may not go into all of them in detail, but I want to emphasize two things. One, all the projects we do have two underlying principles. We have to capture the accurate complexity of our patients, right? Because we want to make sure that our risk scores reflect who our patients are, and when we're doing our quality reporting, it's showing the level of complexity our patients have and why we're doing the things we're doing. The other thing is decreasing utilization, going back to that utilization metric that we're focusing on. So two projects here that I really want to talk about that we're really focusing full steam ahead for this upcoming year. The post-acute care coordination being one of them. We're really working, we know that when you look at the financial data, one area that our spend has increased significantly is with SNF patients and the patients who are staying in the SNFs for an extended period of time and sometimes are lost to follow-up because maybe we don't have the best communication, especially with external SNFs. So we're working on tightening our relationship with those SNFs, not just our H&H SNFs, but those that our patients are going to that are outside of H&H. And how can we know at timely manner when our patients are being discharged, how we can get them into care so we're not losing them to follow-up or, they're going to other health systems because that's where the SNF prefers to send them to, amongst many other things. Even home care is another one we've started to look into this year. I wear multiple hats, but one of the things I do is I do home care services at King's. I'm working on a tailored pilot with our ACO patients. So ACO patients who are getting discharged at King's, we're working on a way that they get a touch point of a home care service and assessment so they're not lost to follow-up, and we make sure they have timely appointments connected to their PCPs for those that can when it's time to resume outpatient care. And we're looking at the numbers of that so we can make sure that, if it's successful, we can potentially scale it to other sites. So I would say post-acute care is really where we're focused on because that's where, when we look at utilization and cost, that's where we see the trend going up, and that's where we're really going into. The other projects, some of them are disease-focused. These are, CHF is the leading cause of readmissions in the Medicare eligible population, not just a unique trend to us, but also to the nation as a whole. So we've really been building on how we're doing care coordination with patients discharged with CHF, self-management tools, Epic tools, all these things. Our frail elderly really pushing for annual wellness visit completion rates, and we've really made a lot of great progress with that, even using my chart, changing how the templates look to make sure that they're capturing all the data elements that we need, and really having a plan for those who are high risk of potentially needing to go back to either inpatient. High utilizer, that remains our flagship project, and that's, to your point, not just limited to the ACO patients, but Metro Plus and Health First patients 18 and older who have 2 or more ED admissions within a 12-month period, among other criteria. There, we make sure that we're calling them, they're getting their 3-day phone calls and 14-day clinical appointments, as well as social determinant of health screening. And chronic kidney disease, we're really trying to, end-stage renal disease is a big issue for us. And one of the things we're trying to do is move further up on that axis and seeing how we can delay progression to end-stage renal disease by really focusing on those who have chronic kidney disease, diagnosing them accurately, not just letting it, patients who have abnormal lab values that point to chronic kidney disease that don't have a diagnosis, notifying their providers, getting them time to intervention with the appropriate guideline-directed medical therapy, and hopefully slowing the progression to end-stage renal disease. So that's just a summary of some of the clinical objectives we have. We have many more coming. Happy to take any questions on that.
This is one thing related to, again, the discharge care or post-acute care. A big chunk of the readmits end up being related to medications, proper medications being given, education, which comes on the hospital end as the patient's being discharged. With the pharmacy, did they get it refilled? So how much time, or how should I put it differently, how much input is there from the pharmaceutical piece in this whole project? I mean, do you, again, particularly the issue of hopefully that whole continuum that they did get the education when they left the hospital, but also that these things are filled, that they had the financial ability to make sure that these were filled and so on. Just curious how that all fits in.
Great question, and it's a very important one. CHF, most of our, I would say 90% of our care coordinators are actually CDTM. So they are clinical pharmacists with backgrounds in pharmacy management.
Great.
They were integral in designing the workflow. Even the workbooks that we gave the patients, they came up with what medications and dosing and how to counsel patients on that. how to even advocate for themselves for even other supplies, in addition, like blood pressure cuffs and all this, what pharmacies provide that based on insurance plans, all of that. They were absolutely integral, and we work with them for many of our other initiatives as well.
Question here.
Yeah, just a technical clarification. How do you define frail elderly?
Sure. So that's a great question. So we use, there are different scales for frailty that we use. The one we're working with the Geriatrics Council on is a clinical frailty scale. Any patient, I think we're at the point where the reason why it's ambiguous is we're still trying to decide for us what we consider to be super frail. So with a score of 7 or higher, those are the ones at the highest risk of frailty that can potentially lead to institutionalization or readmissions. So right now we're working with the clinical frailty scale. The reason we like that scale versus others, it doesn't require equipment. It's a little bit more subjective, so it's really easy to work and integrate into the physician or provider workflow. But we're using the clinical frailty scale.
Thank you.
Okay, anything else? Yes. Thank you so much.
Make just two coming attractions for the board to know. One is we have great leadership. Anthony is a wonderful medical director for us. Megan is a wonderful chief operating officer, both of whom she's been a huge part of our success around our contracting and our revenue, working with Matt. Matt, as people know, has left us except for a small number of hours. He works part-time to help us close out some projects. So we need a new CEO for the ACO. And I apologize that I didn't get to do the formal announcement before today's meeting, but as the coming attractions, it will be Ted Long. And I think it's also significant because we've never seen the ACO as an outside thing. Right. We treat all our patients the same. As Anthony so well explained, we have the same metrics, or Megan talked about, the values that we have. And so we don't want the ACO run by a different set of people, right? Part of why Anthony makes such a great medical director for us is because he's an active clinician at Kings County, which is one of the most important sites for us of the ACO, right? And so that's how we've always done this, and this will maintain that tradition. The other coming attraction is that Maimonides has an ACO, which is separate from our ACO, different set of partners, and we're not sure what the answer is. But I just wanted to mention it because one way or another it will become part of our dialogue. I'm sure it will continue. They too have savings in their ACO. But exactly in what way, whether that will maintain two or we will try to bring them together, I don't know. There are no overlapping partners. But I did want to.
There's no reason you can't have two.
No, we could have two. There's no problem as long as they don't overlap. Right. So and they currently don't. And theirs is a very Brooklyn focused. But of course it doesn't include Kings, which is so the answer is just we don't know. It's not, and we'll talk more. There are things that are critical to get resolved in time for closing, and there are things that are not. And this is an example of an important issue, but does not have to be resolved before closing, because we have an ACO, they have an ACO.
And theirs has been successful as well.
Theirs has been successful. Yep. So if we are one organization at the time of closing, we would have two ACOs. Will we maintain two ACOs forever? Maybe. Will we combine them? Maybe. But because it's a question that does not require an immediate answer, and there are so many other questions that require immediate answers, we will not be bringing that particular question to the board, but it may have an answer sometime during the year. And since this is a periodic meeting, I didn't want board members to be surprised if we later bring you either, two ACOs or a plan to combine them.
Okay. Congratulations.
Thank
you. Okay, is there any old or new business? Since there's no further business, I declare the meeting of the HHC Accountable Care Organization sole member annual Meeting adjourned. Thank you.
Thank you.
This meeting is no longer being recorded.
This meeting is being transcribed and summarized.